Great. Thank you very much, Philippe, and thanks for inviting me. And this course continues to evolve, and it gets better and better every year. And so it's a pleasure to be here again. And thank you for asking me to discuss this topic. These are my disclosures. This is a topic that is very central to my heart because J.F. Tanguay and myself co-chair the Canadian CCS guidelines, and this is a very active discussion that we're having right now about the guidelines. The guidelines won't be released until this fall, so I won't be showing any of the guidelines, but I'll show you some of the thought processes that are going through the committee's mind as we decide on the final outcome of these guidelines. So the main issue I was asked to talk about today is this overlap of patients who require dual antiplatelet therapy and oral anticoagulants. And it's not a small number. It comes to about 1 in 5 to 1 in 6 patients that we do PCI on. And the indication for oral anticoagulation can vary. The most common, of course, is atrial fibrillation, but patients also have mechanical heart valves. They may have had a recent venous thromboembolism, particularly pulmonary embolism, which can be fatal, or they may have established left ventricular thrombus. And the question is, how do we manage these patients after we do PCI? Now, if we focus on the atrial fibrillation question, first of all, and look at the most recent CCS guidelines, they recommend OAC appropriately in a patient with atrial fibrillation who does not have concurrent coronary disease. That's known anyway. So they recommend that if the patient is over the age of 65 or has any risk factor, so even a CHADS-2 score of 1, they would receive OAC. They could have a CHADS-2 score of 0, and if they're over the age of 65, they would still receive OAC. And these guidelines have been well received for patients who don't have concomitant coronary disease, and I think they're appropriate and really very well done. The question, of course, is what do we do when a patient receives a stent? And if we go back and look at the studies that have compared for the prevention of stroke, dual therapy versus oral anticoagulant therapy, in this case warfarin, but the newer OACs also apply, it's better than dual therapy for prevention of stroke. Does that mean that dual therapy is completely ineffective? No, it doesn't mean that, because there was another trial, the ACTIVE trial, that showed that just adding clopidogrel to aspirin in patients with AF does lower your risk of ischemic stroke. About a 28% relative risk reduction in the composite endpoint and about a 20% reduction in ischemic stroke. That's a big effect just by adding clopidogrel to aspirin. So while it's not as effective as adding oral anticoagulant therapy, if you're treating a patient with atrial fibrillation with dual therapy, you are impacting quite substantially their future risk of stroke. And we tend to forget this issue, and it's an important one because it impacts directly on what we do post-stenting. Now, what about on the stent side, and what about how oral anticoagulation is used? And I had to bring this slide back, and this actually almost messed up the whole system because it's such an old slide. And if you ask your fellows, why do we use dual antiplatelet therapy to prevent stent thrombosis? What's the evidence behind it? And you'll see the dates of these randomized trials looking at dual therapy, and in those days it was with high-dose aspirin and ticlopidine versus aspirin and warfarin, essentially. And this is a compilation of all of those trials looking at death or MI. And you'll see in this compilation of all of the data, and we use this as the rationale when we designed the CURE study, there was a big effect, about a 50% reduction in death or MI with using dual antiplatelet therapy versus using aspirin and oral anticoagulation for the prevention of stent thrombosis. Now, you can say these are older trials, and it's true they are. They used the older J&J stent, but it was a bare metal stent. They used ticlopidine and not clopidogrel. If anything, clopidogrel would be slightly better than ticlopidine. And as far as I know, warfarin hasn't changed between back then and now. It's essentially the same drug, and it was also helped by the addition of aspirin. So this is the rationale behind why we use dual therapy versus using an anticoagulant to prevent stent thrombosis. What about the addition of dual therapy to aspirin or a P2Y12 to aspirin? This, again, is going back again many years ago, looking at dual therapy with aspirin and ticlopidine versus aspirin alone. Here, there's a whopping effect. There was a big effect, P0.0001 for the reduction in death and MI, and the hazard ratio here is a reduction of about 75% in events. The reason this is important, and the reason I'm bringing this up now, is because we're looking at dropping antiplatelet drugs. We're looking at maybe we can drop aspirin, maybe we can drop clopidogrel, but we need to remember what the basis was in the first place of why we use these drugs. They were based on these randomized trials, so we need to keep that in the back of our mind as well before we make big leaps of faith in terms of how we treat these patients. And then, of course, in the ACS setting, versus placebo, clopidogrel was effective, and now with the newer drugs, ticagrelor was more effective than clopidogrel, as was prasugrel more effective than clopidogrel. So that's the basis for the use of antiplatelet drugs. And so we have these competing forces. On the one hand, we have atrial fibrillation and the risk of ischemic stroke. On the other hand, we have PCI and ACS and the risk of stem thrombosis. And so what people have done is just put the two together and use an anticoagulant with dual therapy with so-called triple therapy. Okay, well, that's all fine and good. The problem with it, of course, is that when you put these things together, you increase the risk of bleeding, and not by a little bit, by a lot. The increase in bleeding in this Danish registry is on the order of 3 to 4-fold increase in bleeding complications requiring hospitalization. And then we have randomized studies as well looking at triple therapy. This was not in an atrial fibrillation population. This was an ACS population where apixaban was added on top of dual therapy for ACS. And you'll see that with the addition of an OAC, in this case apixaban, the striking increase in the risk of bleeding complications in this randomized comparison. There was also a trial that was done, the Atlas trial with rivaroxaban, which showed that also bleeding was increased in the trial, but there was also a benefit. On the left-hand side, you'll see that adding a very low dose of rivaroxaban, the 2.5 BID, resulted in a benefit, 10.7% versus 8.9%. So how do we take that benefit and put that into context on the right-hand side with the increase in bleeding? And that's one of the challenges. So some of the strategies that people have looked at is maybe we can drop the aspirin. Maybe now that we have DOACs, we have better adherence to these drugs, they're more effective than warfarin, maybe it's now time to consider dropping aspirin. The other question that people are asking is maybe we can just reduce the time that people need on triple therapy. If we use triple therapy, we don't need to use it for 6 months or a year. Maybe perhaps we can get away with a much shorter time. The other question people are asking is maybe we can just reduce the dose of the OAC. Do we need such high doses of OACs when we combine it with DAPT, particularly since DAPT reduces ischemic stroke versus aspirin alone? And then the last question is maybe we should consider both, reduce the dose of the OAC and drop the aspirin. So these are some of the strategies that are now being considered. So let's look at the first one about dropping aspirin. This was tested in the WOEST trial. Now, the WOEST trial was a single-center study, 800 patients. It was an open-label trial. And they looked at dropping the aspirin immediately after the PCI. On the day of PCI, everyone received aspirin. I think that's important. And then on the day after was the first day that the aspirin was dropped. And in this trial, they showed a reduction in bleeding with dropping aspirin, quite a striking reduction in bleeding. These are clinically significant bleeds, but not the TIMI major bleeds that we were talking. So these are not exsanguinations. If the doctor had to go back and look at a groin or look at a wrist for persistent oozing, then that would qualify in this trial as a bleeding event. And remember, it's an open-label trial as well, and there is some subjectivity in deciding on what's a significant bleeding event and what isn't a significant bleeding event, particularly as your definition of bleeding becomes less less stringent. But nevertheless, I think the results are what one might expect when you use one anticoagulant versus two. And then on the efficacy side, they didn't show a significant harm with dropping the aspirin and treating with clopidogrel alone. But remember, in the study itself, it was relatively underpowered for this comparison, and it was open label. So I think we need to take this with a grain of salt, but it certainly didn't show there was this huge increase in stent thrombosis that a lot of people might worry about. Now, a second trial was done in Germany, the IZAR triple study, and this trial took a little bit of a different approach. They decided to treat everyone with triple therapy, but one group received only 6 weeks of triple therapy, and the other group received 6 months of triple therapy. The group that received 6 weeks of triple therapy had their clopidogrel dropped, not the aspirin. The clopidogrel was dropped at 6 weeks to see if that would have any impact on bleeding. And you'll see in this slide that for efficacy anyway, it didn't seem to matter, although you'll see early on there a separation of the curves in the 6-week group. It seems to separate early when both groups should have had the same therapy, which I'm not sure I understand. But even within the first month or so, there appears to be a separation, and then the curves seem to come together after time. And then you'll see this is, again, the secondary endpoints looking at the early risk and the longer-term risk. And then on the right-hand side, the bleeding risk. And overall, they did not see a difference in bleeding in this study between the longer triple therapy versus the shorter duration of triple therapy, which is a little puzzling. But they did this landmark analysis and suggested that after the 6-week mark, there may have been a reduction in bleeding, which is what you would expect because that's when the treatments differ from each other. And then we have the most recent study, the Pioneer trial, which was a complicated study, but addressed a few of the issues that I touched on earlier. So in this trial, 2,100 patients with atrial fibrillation receiving a stent were randomized to one of three strategies. The bottom row is the triple therapy, traditional triple therapy strategy with aspirin, ethinoperidine, which was far and away, most commonly it was clopidogrel, and then warfarin with a target INR of between 2 and 3. So that was the anchor arm. That's the regimen that many people were using previously. And then there were two experimental arms. The top line shows you the WUST-like strategy where rivaroxaban and a dose of 15 milligrams daily was used in combination with mostly clopidogrel. In this trial, 95% clopidogrel. Aspirin was dropped on the next day. But remember, it wasn't dropped on the day of the PCI, and randomization in this trial that could have happened within 96 hours or 72 hours of the procedure. So please don't, omit aspirin altogether, particularly in an elective patient, saying that Pioneer ACS said it was safe to do that. At least give a loading dose of aspirin before the procedure, and then if you wish, if you want to stop aspirin at some point afterwards, go ahead. But boy, wouldn't it be a tragedy if people took this trial and said that we don't need aspirin. So an elective patient comes in, let's say they're on, dabigatran or apixaban. That drug is held before their cath procedure. They come in, you do a bifurcation stent procedure, and the patient never even receives aspirin because they weren't previously on aspirin, and somebody wants to follow the Pioneer trial. So what they do is they just give a 300 milligram loading dose of clopidogrel, and then the patient goes home. So the apixaban was held, the aspirin was never given, and all they've been treated with is 300 milligrams of clopidogrel. Depending on the risk of your PCI, that would not be a good scenario. So although the WUST-like strategy in the first row of this study dropped aspirin, they all received aspirin before the PCI. And that point gets lost, particularly when our non-invasive friends describe the results of this trial. This middle arm of the trial is the Atlas-like arm where they did use triple therapy, but they dropped the dose of the anticoagulant rivaroxaban to a very low level, 2.5 milligrams BID. And they allowed people to give it for as long as they thought. So they asked the investigator before randomization, do you want to give triple therapy for 1 month, for 6 months or for 12 months, and they had to pre-specify before the randomization occurred. And you'll see the majority in the trial, 49%, gave it for the full 12 months, 35% for 6 months, and then 16% for 1 month. It's important to note that this is not a randomization to duration. This is just a background treatment, and that within these durations of therapy, there is the randomization. So it's perfectly valid way to do the study. And you'll see the baseline demographics here. What I'd like to point out to you is that the CHAD score, you'll see the CHAD's score more than 89% of patients had a high CHAD score greater than or equal to 2. So by and large, this study applies to people who have a high CHAD score. And then you'll see the types of atrial fibrillation below. It was almost an equal division of persistent, permanent, and paroxysmal AFib. The trial was almost entirely clopidogrel. A small proportion received ticagrelor, about 5%. Very few number of patients on prasugrel, but not zero. And then 60% of patients were elective, 40% of patients were urgent. And about 2/3 received a drug-eluting stent. Surprisingly, a third of patients still received a bare metal stent in this trial. I'm not sure what that's reflecting, whether that's more US practice, but certainly I know in the province of Ontario, well over 90% of patients receive a drug-eluting stent. And you'll see the results here for their primary endpoint, which was clinically significant bleeding. There was a significant reduction in both of the two rivaroxaban-based regimens, approximately 17% and 18%, and the warfarin-based triple therapy arm had a bleeding event rate of 27%. So, a big reduction. It was highly statistically significant, and it was, a convincing reduction in clinically significant bleeding. What about on efficacy? Well, they didn't see any differences in efficacy between the three groups. You'll see the event rate 6.5, 6.0, and 5.6, and the curves are all overlapping with each other. But it's important to remember the trial was not powered for efficacy. It was significantly underpowered in this regard. They would need a much larger trial to see any significant difference, but I think what you can conclude is there is not a catastrophic increase in efficacy or compromise in efficacy with the strategy. Now, Mike Gibson, being the excellent investigator he is, fully recognized the limitations of that trial. The main limitation of that trial is efficacy. So they had pre-specified an analysis where it's a retrospective analysis where they looked at the outcome of rehospitalization or death. And when they did that, and there they did have significant power, and when they did that, they found that it was reduced in the two rivaroxaban-based regimens compared with the warfarin-based regimen. So it supports the efficacy results. Does it clinch it? No, because it was a post hoc comparison. There were some problems with it, but certainly it's more supportive evidence that you would want for efficacy. And remember, we have no other trials that are giving us efficacy in this regard. In this study, they saw a reduction in cardiovascular endpoints as well as in bleeding endpoints with the two rivaroxaban-based regimens. And then they made a point of showing this slide, which shows what power you would have for efficacy if you had a 20% relative risk reduction. And so on the left-hand side, you have the analysis that I just showed you, 80 to 90% power. On the right-hand side was the main study for death MI stroke, about 16 to 17% statistical power. So, I think the two comparisons are supportive of each other. They don't clinch efficacy by any stretch, but when we have a data void and we have to lean one way or lean another way, I think this data would make us lean towards thinking it probably is safe, but we don't know for sure. Now, there will be some more data, which is the good news, and the redual PCI trial will be presented at the ESC in late August. And this trial is a 3-arm trial comparing, again, warfarin-based triple therapy with 2 doses of dabigatran, 110 BID and 150 BID. This trial was initially supposed to be a 9,000 patient efficacy trial, looking, powered for efficacy endpoints, but there was a challenge in recruitment in the trial because the main objection was investigators did not want to put the patient back onto warfarin. So because of that challenge, they decided to make the primary endpoint major bleeding, and that will be, composite of bleeding and efficacy. So bleeding, death, MI, and stroke will be their primary. And they've redone the sample size calculation, and now it's going to be approximately 4,000 to 5,000 patients in total. Still a good size study. And then there is another trial that's significantly well away from reporting. This is a trial with apixaban versus warfarin in patients with AFib, the Augustus trial. In this trial, they'll take AF patients and patients with CAD. They don't have to have had a stent. They could be a non-stented patient with CAD. And they're randomized to either apixaban or warfarin. But again, the apixaban dose here is not a dose reduction in apixaban. They're using the full 5 milligrams BID, and then a sub-randomization to aspirin or placebo. So potentially you could have apixaban 5 milligrams BID, you could have aspirin, and then you would have clopidogrel. So the triple therapy regimen on board, and that was the regimen that they had studied in the APPRAISE trial. So, it'll be interesting to see what the results are here. The neurologists will like it because of the full dose apixaban. We'll see how the interventional cardiologists respond to the results of the trial. But it's a fairly bold study without dose reduction of the OAC. And then the edoxaban trial will be using the lower dose of edoxaban versus warfarin, a much smaller trial, a much softer endpoint of clinically relevant bleeding. Now, the CCS AFib guidelines came out with recommendations last year. And what that committee decided to do was break up the patient population into those with elective PCI and those who have ACS. And I'm going to talk a little bit about that because, in the modern era of PCI, that distinction is not so clear any longer because our elective PCI sometimes are the highest risk procedures that we do. And so this is something that the CCS received a flurry of email about. But I'll just take you through this, or letters about. I'll take you through this. So on the left-hand side, what they recommend is if you're age under 65 or CHAD 0, you should receive dual therapy, and then that should be followed by aspirin alone. So you don't need to have an OAC on board if you're at low risk of ischemic stroke. On the right-hand side, if you have a slightly higher risk of ischemic stroke, so age over 65, even if your CHADS 2 score is 0, they would recommend the addition of OAC plus clopidogrel with no aspirin. And they would recommend that regimen be given for 12 months, for up to 12 months. And then the ACS group is here, and I'm going to focus only on the PCI groups, not the no PCI, because the no PCI to many is a bit confusing because that group implies patients with CABG surgery, implies patients who are treated medically with medical management. They're vastly different populations of patients, and we're not sure exactly what the committee meant by no PCI. So I'll just focus on the PCI ones. So the low risk patients on the left-hand side, the age less than 65 and CHAD 0 PCI patients, they recommended aspirin and ticagrelor or prasugrel or clopidogrel, so just dual therapy for 12 months. And on the right-hand side, they recommended a triple therapy regimen with an OAC, clopidogrel, and aspirin for 3 to 6 months, and then drop the aspirin and treat with dual therapy with OAC plus clopidogrel. So some of the main things, I think the guidelines, the framework of the guidelines are outstanding. But the CCS did ask us, JF and myself, to co-chair a committee to look at some of the issues. And there were 3 main issues that were identified. And the CAIC had written a letter outlining some of this. So the first one is that the risk of stroke should be high enough to justify adding an OAC to DAPT. Given what we know about the risk of bleeding, there has to be some semblance of risk that puts a patient, that a patient should be able to go on to an OAC regimen on top of antiplatelet therapy. So for the current guidelines, there's no distinction between a patient who is receiving atrial fibrillation has atrial fibrillation with no CAD, and a patient who has atrial fibrillation with a stent placed. They use the same criteria for OAC. So that was the first point. The second one was some elective PCIs are very high risk for stent thrombosis. So you can think about your surgical turn-down patients, your complex bifurcations, your left main. Most left main lesions are not ACS. They're actually elective patients who come in. Some are complex left main bifurcations. Some are simple osteal left mains, which you can do in 5 minutes. I'm exaggerating, but there's a spectrum of left main disease there. There's multivessel PCI, and multivessel includes a lot of our surgical turndowns. There are the small vessels and the long lesions, and then the chronic total occlusions that are all elective PCI. But many of them receive a lot of stents. Some of them full metal jackets. So these are patients who all are at dramatically increased risk of stent thrombosis. There was a nice paper by Antonio Colombo last year showing that. And the risk of stent thrombosis is about the same as a patient with ACS. And in some low-risk ACS patients, the risk of stent thrombosis is not as high as in these patients groups with elective PCI. And so the recommendations should consider the high-risk elective PCI patient similar to the ACS patient in terms of for the prevention of stent thrombosis. It's an artificial separation elective in ACS. The third was that the recommendations need to be flexible enough to allow appropriate clinical judgment of ischemic and bleeding risk to determine the duration of time on triple therapy. So there's a vast array of patients who have different risks of ischemic events and bleeding events. You may do a frail 95-year-old versus a 65-year-old who has a relatively low risk of bleeding. Those two patients may receive entirely different durations of triple therapy and need to be considered differently. So no guideline can be so rigid as to tell a practitioner this is the way to do it. It needs to acknowledge that variability in patient risk. And I think these were some of the main issues that will be tweaked in the new set of ACS or of antiplatelet therapy guidelines that will be coming out. And I can't really say any more than that. I'm just going to skip these ones and just go through some of the strategies that have been offered to minimize the risk of bleeding, and I'll just repeat some of these. So the first is, use the lowest effective dose of a NOAC. So don't use maximum dose of NOAC if you need triple therapy. Why? Because if you take a patient, let's say you take a patient with a yearly risk of stroke of 6% per year. That's about a CHADS 3 or CHADS 4. Between a CHADS 3 and CHADS 4 is about 6% per year. And you want to use triple therapy in a patient for 1 month. The monthly risk of a stroke in that patient will be 0.5% per month. If you look at an average risk of stent thrombosis, particularly in a more complex patient, that's about 1%. It's all front-loaded. Stent thrombosis is all front-loaded, and it declines after the first 4 weeks. So during that period, the dose of NOAC could be dropped down. I'm not saying there's zero risk, but it's a relatively minimal risk of doing that. And then the NOAC dose can go back up once you decide to drop one of the antiplatelet drugs. If aspirin is used, use low-dose aspirin. Here, it's not an issue. South of the border, still a big issue. They all use 325 milligrams of aspirin. Use clopidogrel over ticagrelor or prasugrel. I haven't shown you the data, but there were 2 big registries that have come out with triple therapy showing dramatically higher risks of bleeding with the latter 2 drugs in the context of triple therapy. Consider a concomitant PPI, and this is particularly for vulnerable patients who may be at risk of GI bleeding. And if a vitamin K antagonist is required, set the INR target range between 2 and 2.5 and monitor via an expert clinic, or if you're on your own, do more frequent monitoring while they're on a triple therapy regimen. Now, I'll just move on, and I've been asked to say a few words about perioperative management. And perioperative management after a stent is, also a controversial issue. And it's also a balance between the risk of postoperative bleeding on the one hand, and then the risk of stent thrombosis on the other hand. There was a document that just came out earlier this year by a number of experts, which looked at this whole issue of how do you manage antiplatelet therapy in a patient who needs a non-cardiac surgical procedure. And they offer 3 steps in doing this. The first step is to determine the thrombotic risk, and they divide the risk into low risk, less than 1%, intermediate risk, 1 to 5%, and high risk, more than 5%. And this is largely the risk of stent thrombosis that we're talking about here. Whenever we talk about stents, the main risk is stent thrombosis. MI is secondary to stent thrombosis. That's really the key here. And on the right-hand side, you'll see the high-risk patients. They consider is if you're going to have non-cardiac surgery within a month of a BMS or within 6 months of a DES or any type of complex intervention within 12 months with a DES. Those are the patients they consider to be at high risk. The second is determine the hemorrhagic risk of the actual surgical procedure itself. And you'll see here they've gone through this painstaking effort of dividing all of the various surgical procedures into low risk, intermediate risk, and high risk. High risk surgical procedures are things such as neurosurgical interventions, very major intra-abdominal surgery, hip surgery, interestingly enough, is at very high risk of bleeding, major pelvic and proximal femur fractures, nephrectomies, cholecystectomies, TURPs, prostatectomies, open thoracic or thoracoabdominal surgery. These are all considered high-risk procedures. Some of the surprising things to me, the intermediate risk category, open AAA surgery is considered intermediate risk, not a high-risk procedure. And then you'll see on the left side, the low-risk procedures are things such as carotid endarterectomy, EVARs, limb amputations, interestingly enough, are considered low-risk surgical risk procedures. And then they look at the hemorrhagic risk and the risk of stent thrombosis, and they made this 2x2 table, and they offered some recommendations. Now, if you look on the right-hand side to the high thrombotic risk patient, which is really the one that we worry about, the patient who needs cancer surgery within, 4 weeks or early cancer surgery, and there really is a pressing need to go to the OR. Their recommendations on the right-hand side are, of course, discontinue the P2Y12 inhibitor if possible, and then resume it 24 to 72 hours afterwards, and consider bridging with a short-acting IV antiplatelet drug. So essentially what they're telling you is there's not much you can do about it, folks. If this situation happens, and you're not able to delay the surgery, then you just have to take the hit, hold the P2Y12 inhibitor, particularly if they have a high-risk surgical procedure. Consider bridging, although the evidence is not really there for bridging. These investigators are recommending it. We don't do that in Hamilton, but I know there are centers that do bridge with, and that's fine because it's a data void. We really don't know the answer. They bridge with either Cangrelor. Cangrelor is not available in Canada, but with tirofiban or one of the other GP2B3 inhibitors. Here is just a summary of that, and the new CCS guidelines will go through some of this in more detail. If they have a BMS, if you can delay the surgery for a month, if it's elective surgery, if it's a DES, delay the surgery for 3 months. So it differs from the American guidelines of 6 months CCS, and our antiplatelet committee has always used 3 months for DES, particularly with the second generation DES. We don't think 6 months has to be the cutoff. Continue aspirin wherever possible. Hold the clopidogrel and ticagrelor for 5 to 7 days preoperatively, prasugrel 7 to 10 days preoperatively, and then restart with a loading dose post. Now, what if a patient needs CABG surgery specifically? So, whether it be a patient with ACS or an elective patient who comes in from home and you do an angiogram and they have left main disease and they've got to go to the OR. So the recommendations, again, very simple. Number 1, continue aspirin. Number 2, this is new. Sorry, ticagrelor is misspelt there, but hold the ticagrelor or the clopidogrel for 5 days pre. So previously that was 5 to 7 days. The 7 days has been removed based on new data. And the minimum duration for going to the OR is a 24-hour wait. So that's for a patient who may have a big bulky thrombus in their left main. You're very worried about them. Patient who's in your CCU with a balloon pump on pressors and in cardiogenic shock. This is the minimum duration that we're recommending with these drugs prior to CABG surgery. And then, or that I'm recommending. The committee's not recommending it yet, or they may not recommend it. We haven't voted yet. And then the prasugrel, hold the prasugrel for 7 days. The minimum duration of prasugrel is for 5 days prior to cabbage, and that's also based on data that show, because prasugrel is a covalent bond, it's a very potent agent. It's not reversible like ticagrelor is, and that's the recommendation for prasugrel. Now, the other question we've been asked often is, how long do you hold the NOAC before an elective PCI procedure? And lots of cath labs have different approaches to this. There have been recommendations that have been published on it. And the recommendation for dabigatran, and they all depend on renal function, as you might expect. So for dabigatran, if the creatinine clearance is more than 50, then you can hold it 24 hours prior. But if it's reduced even moderately, creatinine clearance of between 30 and 50, and we're talking about most 80-year-olds have creatinine clearances in that range. It's a 2-day hold, and then if the creatinine clearance is below 30, then we're talking about holding it for 4 days. So it's, dabigatran, as you know, is very sensitive to renal function, which is maybe one of the reasons why it may not be the first NOAC people reach for. It's a highly effective one, but you do have to pay attention to the renal function with dabigatran. You also have to pay attention to renal function with the other two, of course. Rivaroxaban, if the creatinine clearance is more than 30, then 24 hours, so the day prior, hold it. And then if the creatinine clearance is low, like below 30, then hold it for 2 days. And then the apixaban, if the creatinine clearance is over 50, then hold it for 24 hours. If it's between 30 to 50, then the recommendation is to hold it for 2 days prior. So I think gradually there is a merging of most cath labs in their operations at the level of triage and how this is being done. But this is something that would be important to consider. You don't want them off it longer than they have to be, not that there is a dramatically increased risk. So you do want them to be on it. You wanted them to be off of it, but not longer than they necessarily have to be. So I think I'll leave it there, and then maybe we can have a discussion about some of these recommendations.